So I think in the general community, there's a sense that we have a large number of agents for the treatment of patients with CABP. But if you look at the guidelines, what we really see is a limited number of drug classes. And largely what we're left with is use of a beta-lactam, and for our inpatients in combination with a macrolide, a fluoroquinolone, the respiratory fluoroquinolones, and most of us are aware of many of the increased box warnings associated with them. Doxycycline, which is a drug that is considered in the guidelines but has limited evidence for use in CABP, and our two newer agents, omadacycline and lefamulin. So I think we kind of look at the guidelines, we see there's a lot of different treatment options and some variations, but most of those are variations within the drug class. Clearly, we can use broader spectrum agents, vancomycin, linezolid, even our anti-pseudomonal beta-lactams. But good stewardship practices tell us that this use should be avoided, particularly among patients with community-acquired bacterial pneumonia. So overall, I think we do have agents, but I think they're limited, and I think lefamulin and both the omadacycline are two welcome additions to our armamentarium for the treatment of adult patients with community-acquired bacterial pneumonia. I think first and foremost, it's a disease state we treat empirically. And as indicated by the guidelines, collection of sputums and other respiratory samples are no longer recommended, and blood samples should only be collected in individuals who are at high risk for septic shock. So really, it's become a disease state that we treat empirically. So there's really two consequences to this. First, you don't always know exactly what you're treating. I think we have a good sense of our community-acquired bacterial pneumonia CAB pathogens. And again, it's still strep pneumo, Haemophilus influenza, Moraxella, and some of our atypicals. However, we don't know exactly what we're treating. So a consequence of that is we use initial broad-spectrum antibiotics, and we really have limited opportunities to de-escalate, if we knew what the pathogen was. I think the other biggest thing with CAP is, I just mentioned in my previous answer, we have a limited number of agents. So again, we have a lot of agents, a lot of different beta-lactams, macrolides, fluoroquinolones to choose from. However, there's some class effect. For example, if someone's allergic to penicillin, you can't use amsulbactam, amoxicillin, and you may or may not be using some of the cephalosporin antibiotics. If someone has an allergy to a fluoroquinolone or they're a high-risk group for one of its adverse events, this is a class effect. So I think the second major treatment challenge in patients with community-acquired bacterial pneumonia is just a limited number of class agents available. Also, as part of that, historically we used a lot of monotherapy with macrolides. Most regions in the United States have greater than 25% resistance. And in that scenario, even a patient without comorbidities, macrolides are no longer reckoned as monotherapy agents. Fine in combination. I think they have shown some increased survival benefit in some of our sicker CAP patients, but we have lost the macrolides as a monotherapy agent in the outpatient setting in patients without comorbidities. Third biggest challenge, I still think, is site of care. I think we have some good triaging tools to identify the initial site of care. The one advocated by the latest iteration of the community-acquired pneumonia guidelines is the PSI score, pneumonia severity symptom score, also known as the PORT score, originally developed by Fine et al. And really what this helps us to assess based on the PSI risk category, the initial site. So, PSI 3 is outpatient, 4 and 5 are inpatient, and even the 4, some of those can require only a short stay. So, while we have these guiding tools, clinical judgment always prevails. But what the literature tells us upon closer inspection, there's considerable variability among institutions in admitting patients with community-acquired bacterial pneumonia. Part of that is we're probably admitting a lot of patients we do not have to. The reason why I mention it is, with the Affordable Care Act, it's the quality efficiency of healthcare. And what we find is that single decision to admit a patient with CAB, whether they need it to or not, or could be managed in an observation unit for 48 hours, is associated with costs upwards of $10,000 to $15,000.